Welcome back to the third and final part of this teaching session on health impact assessment. My name is Joanna Purdy, and over the course of the next 50 minutes or so, I want to cover the final stages of health impact assessment with you. In the last presentation, we looked at screening and scoping, and now we're going to move on to look at the analysis, reporting, implementation, monitoring and evaluation stages of health impact assessment. The main focus of this presentation will be the analysis stage, which really could be considered the central part of the health impact assessment process. The analysis is the stage in which the evidence of potential health effects is gathered and considered, and when conclusions are drawn. The analysis may include conclusions on the significance of health effects, and we'll come to that shortly. Methods used for data collection and analysis may vary depending on the level and reporting format or type of the health impact assessment. At the analysis stage, we present a conceptual model similar to that used at the scoping stage of the evidence sources that enable a consistent and transparent approach to analysis. When analysing the significance of an effect, there is always a degree of professional judgment. The HIA team needs to take uncertainty into account as well as use flexibility in the way that any given framework is applied. The conceptual models enable the full range of evidence to be included, to show uncertainty and to enable consideration of what changes resulting from the proposal mean in terms of importance, acceptability or desirability for population health. This guidance also supports practitioners to articulate their reasoning and conclusions with a brief structured narrative. The conceptual models, which we will come to shortly, form the basis for this structured narrative. Moving on then to gathering evidence. HIA is an evidence-based approach, and so the evidence must be relevant to the context of the proposal and the affected population. Qualitative and quantitative approaches can be used and can be used in combination. Quantitative health methods are for those occasions where robust exposure response functions obtained from high-quality epidemiological studies are established. They're also for the times when effect size and population size make it appropriate for this type of evidence to be considered, and also for those occasions where it is proportionate to undertake such analysis. I just want to talk a little bit about some of the sources of evidence in relation to the population first of all. The first of those would be the scientific literature, and the literature can indicate if there is evidence to support an association between the proposal-related change, a relevant determinant of health, and a relevant health outcome. The baseline conditions then establish if relevant sensitivities or inequalities identified in the scientific literature are actually present within the population being considered as part of the HIA. The health priorities then can identify if relevant determinants of health or health outcomes have been identified as particularly important either locally, regionally or nationally. Other sources of evidence are what I've described here as contextual, and these can include the policy context in the area, a consultation for the proposal, and for example regulatory standards in the jurisdiction. So just to think about the policy context and the definition given here. So this can identify local or national government position statements that raise particular expectations for the relevant proposal change, determinant of health or health outcome. Consultation response themes can indicate the extent to which stakeholders and the public support or perhaps have concerns, uncertainty or ambivalence about the relevant determinants of health or health outcomes. And then regulatory standards. Such standards, where applicable, can identify where there would be formal monitoring by regulators. I'm not going to go into detail about all the different sources of evidence, but I think it is important to highlight some features of the scientific literature which you should take into consideration. Firstly, scientific literature is the evidence used to support an association between the proposal, a relevant health determinant, and health outcome. Careful consideration should also be given to the internal validity of the evidence, i.e. the quality of the study, but you must also consider the external validity, that is the generalizability of those findings to the particular context that is being studied. You should also take account of the strength of the evidence, including any emerging evidence. And in the first instance, it is always advisable to search for the highest level of evidence first, i.e. systematic reviews, followed by meta-analyses. You may also wish then to look at individual studies such as randomized control trials. And finally, my advice to you would be to only resort to the grey literature where no better quality studies are available. Part of the process of gathering evidence is to create a picture of the population which may be impacted by a particular proposal. And we call this a population or a community profile if we're looking at a smaller group of individuals. So building a population profile, well, what does it do? Well, it helps to develop a better understanding of those affected by the proposal. And we'll see that when we work through our case study on the 6th of October. We'll give you some information about the population being impacted by a particular proposal, and you'll get an idea of the profile of that population or that community. It helps to potentially identify vulnerable groups within the population, and as well as that, establish a baseline against which possible future health effects can be assessed. This will be important for the monitoring going forward. The benefits of a population profile are that it can be helpful at the scoping and the analysis stages. The analysis stage should focus on the baseline evidence towards specific conclusions on a particular health determinant, for example, population health status or deprivation data informing sensitivity to changes in healthy lifestyles. It's good practice to include only baseline data relevant to and linked to the analysis. Throughout the analysis stage of HIA, you'll hear the terms likely and significant quite a lot. This slide defines these terms likely and significant and what they mean for human health. The phrase likely and significant come from environmental assessment, but also apply to standalone health impact assessment. Standalone HIAs do not always explicitly rank or score significance. However, all HIAs should have a focus on those health effects that are, in professional judgment of the HIA team, likely and potentially significant. So let's look at these definitions. Likely is defined as likely health effects are those that, based on the scientific literature, have a plausible theoretical link between the source pathway receptor, the occurrence of which in the relevant context is probable based on professional judgment. Significant health effects then are those that, based on professional judgment, are important, i.e. they have a positive or negative effect, are highly desirable, i.e. have a positive effect, or unacceptable, would have a negative effect for population health with regard to the changes that are triggered by the proposal in question or the proposal that has been subject to the health impact assessment. And these terms will become more apparent and more explicit as we look at the conceptual model. So we'll not go into any further detail at this point, but we will a few slides further along. The technical guidance provides some assessment guide questions when it comes to making decisions about the significance of a health effect. I just want to talk you through some of these questions for a moment or two. So under part A, we can see in this particular illustration, it asks, is there both a relevant change and a relevant population? And this relates to what we describe as the magnitude and the sensitivity. So is the magnitude of change, i.e. is the impact of change as a result of the proposal, high or medium? And is the sensitivity of the affected population high or medium? In other words, how likely is it that the population will be impacted? What will be the effect on this particular group of people by this proposal? And this takes into account vulnerable groups when considering the sensitivity of the affected population, because we know that the process of HIA is to help reduce those inequalities and the unequal distribution of effects within a particular population resulting from a proposal or a project or a plan. The second question falls under category B. Is the expected change in population health important, i.e. is it potentially significant? So question 2 draws us back to our scientific literature. Is there a causal relationship or a clear association between the changes that would result from the proposal and the changes to health outcomes? And the focus here is on relationships or associations that are of sufficient effect size to meaningfully influence the population health. Question 3 then relates to changes in baseline health. Could the proposal result in an important change to health baseline? This could be a substantial change, or it could be a small change in a large or highly vulnerable population. But it also needs to take account of any mitigation that has been secured. So if any measures have been put in place to circumvent the changes, those also need to be considered. Question 4 then looks at health priorities, and it asks, have health priorities been set out for the relevant study area that are of specific or general relevance to the determinant of health or the population group affected by the proposal? So that's where the HIA team needs to look at local or national health priorities set by government or at a local level. Question 5 then falls under category C. Is the expected change in the population health acceptable or desirable? Again, looking at whether it is potentially significant. And question 5 asks, could changes due to the proposal have a substantial or influential effect on the ability to deliver current health policy? Is this proposal, is this legislation, is this plan going to impact on the ability to deliver current health policy, for example? Question 6 then takes account of regulatory thresholds and asks, could a change due to the proposal result in a regulatory threshold or standard being crossed or nearly crossed? In other words, is this potentially going to breach regulatory standards or planning conditions, for example, or planning regulations? And finally, question 7 takes into account the consultation responses that we mentioned just a moment ago. Have themes emerged in the consultation for the proposal or on the relevant determinants of health or health outcomes? Is there a consensus or is there a mix of view among stakeholders? A positive response indicates a significant effect, and a negative response to these questions indicates a non-significant effect. All the relevant guide questions and their supporting evidence collectively inform professional judgment. Earlier in the presentation, I mentioned this idea of conceptual models, and we have already seen this in place during the scoping stage of the HIA. This conceptual model shows the thought process that builds to a decision on whether there is a significant population effect due to the proposal. It can be used as an aid memoir, a crib sheet, or a workshop tool. It's consistent with the overarching environmental impact assessment and strategic environmental assessment methods, and it sets out the concepts specific to health assessment. The conceptual model set out in this slide can inform the methods statement for health and environmental assessments or in standalone HIA reports. But it need not be reported in the format and detail presented here. For example, it could be referenced, summarised or tabulated. We don't necessarily need to set it out in this format. The steps involve characterising criteria relevant to sensitivity, magnitude and contextual considerations. So first of all, let's think about the sensitivity of a population. This can be informed by some or all of the following. It could be life stage, deprivation, health status, daily activities, inequalities, outlook, capacity to adapt, or resource sharing with the project. Sensitivity is considered in relation to the general population and vulnerable groups. The magnitude of change then can be informed by some or all of the following. So magnitude can be impacted by the level of exposure, scale, duration of the project, frequency of an activity, severity of an activity, the population extent, outcome reversal, and/or service quality implications. And as I mentioned previously, we have the evidence sources then to support the decisions around significance, and those are the scientific literature which we refer to, and the policy context as well. In this particular conceptual model, we're going to focus on health sensitivity, and this is the sensitivity of the receptor to change, i.e. how will individuals, communities, populations be affected by a new piece of legislation, plan, or project, for example. It includes what we describe as consideration of the receptor's capacity to accommodate changes brought about by the proposal. How well can people respond to change, or how well can they adapt to new circumstances in their area or in their community? The model shown in this slide provides different components for sensitivity. For example, it uses criteria, these segments. For example, life stage, inequalities, deprivation, health status. And then within that, it uses what we call indicative classifications or levels to explore and explain the sensitivity of a finding. So for example, that might be under inequalities, that could be narrow, narrowing, widening, wide. Or in terms of daily activities or health status, that could be health status is good through to very poor. So those are what we call the indicative classifications or the levels. Now, Table 11 within the technical guidance provides a detailed definition for each of these. And it's important to note that conclusions may be summarised as high, medium or low, or perhaps negligible to sensitivity, sensitivity to change. The conceptual model then provides the basis for the narrative description of the potential health effects. And I'm going to talk you through an example that's already included in the technical guidance, and I hope this explanation makes sense as we work through it. So it really comes in two parts, what I would describe as a literal phrasing and then a more refined, bespoke, tailored phrasing. So first of all, if we look at this particular example, in relation to life stage, we know from the evidence that has been gathered that a high proportion of the population is characterised as providing a lot of care. So we have a lot of dependent individuals in this particular community or population requiring a lot of care. The population's health status is characterised as poor. That may well be from a self-reported questionnaire. And the population is reliant on resources shared with the proposal and are judged to have a limited capacity to adapt. So these are some of the descriptors of this particular population. Based on these four criteria and descriptors that we have highlighted just now, this population could be described as having a medium or high sensitivity to a particular proposal or a particular change in their community. If we kind of develop a more refined phrasing that we might include within our HIA report, it might read something like as follows. Routine statistics show how, and then you would put in the name of the area. It might be North Belfast, for example. A high proportion, that could be 40% of the population provides care, and a high proportion, perhaps 60%, describes their health status as poor. Furthermore, the population, including carers, makes full use of the social care services affected by the proposal and are judged to have limited capacity to adapt. This population is thus sensitive to change and with a ranking of medium to high sensitivity. So it's really important when we think about the impact that a particular proposal is having on a population, that based on the evidence that has been collated, whether it's that routinely collected data from, for example, health survey data, self-reported data, statistics on health and social care usage in this particular area, that those together, along with professional judgment, are used to reach a decision about the health sensitivity of this particular community to this particular change or proposal. Magnitude considers the characteristics of the change which would affect the population as a result of the proposal. For example, this could be the duration, the severity, or the frequency of the change. These characteristics are defined in Table 12 of the technical guidance, but I'll give you some examples in a moment. In the previous slide, like the previous slide, the model shown here uses criteria or segments and indicative classifications or levels, i.e. or layers, to explore and explain the finding of a magnitude. The conclusion may be summarised as high, medium, low, or negligible magnitude of change. And just for a moment, I want to kind of define some of those for you. So first of all, exposure. So this tends to vary with proximity of the population to the source, or how close the population lives, resides, or works in relation to the particular proposal or aspect of the proposal that is likely to impact their health. Exposure also has an important time dimension to it in terms of health. For example, it could be a case of low concentrations of toxins or pollutants over a long period of time, or high concentrations over a short period of time. So exposure would relate particularly to projects. The other one that I want to give you by way of example is duration. The length of time an effect occurs The length of time an effect occurs for is a key consideration for health. Typically, effects that continue for a long duration tend to be of greater magnitude and may indeed kind of have intergenerational effects. They may last for more than one generation. Where the effects are best characterised as short term, other effects such as scale and exposure may still indicate that the change is of high magnitude, i.e. short-term effects are not automatically of low magnitude. Appropriate reference periods for the duration should be selected, as some proposals can span weeks whilst others can span decades. And as you can imagine, strategic level projects will have longer term implications than project level proposals. The other one I just want to give an example of is severity. So health severity relates to the type of health outcome affected, such as changes predominantly related to mortality, disease, nuisance, or well-being. It may also relate to the type of change relative to the baseline, for example, the onset of new conditions, a change affecting existing health conditions, or a change in the day-to-day functioning for the population. While changes in mortality indicate a higher magnitude than changes in well-being or quality of life, which we might consider to be less severe, this should not preclude a large change in quality of life from being considered of high magnitude. It underlines the importance of using this analysis of multiple criteria as a guide for writing that structured narrative, or that comprehensive narrative that contextualizes each decision and the interrelationship between the factors impacting health of a particular proposal. The third and final model is the health significance conceptual model that I want to talk you through. And this is where we're building towards reaching a decision about the significance of a particular health impact for the population being considered. So, as we've already mentioned, significance relies on informed expert judgment about what is important, desirable, or acceptable with regard to changes triggered by a proposal. This particular diagram provides different components of significance, and again, like the other two, it uses the criteria or segments and indicative classifications to explore and explain a finding. That brings us to a decision as to whether a health effect is significant or not. So in terms of those criteria, we can see the magnitude of change, the sensitivity of the population, again, building on the information obtained from the previous two conceptual models. We also at this point bring in the data that has been collected and both the scientific literature about the population and the policy context as well. You can see there the scientific literature, the health priorities, the baseline information, the consultation responses, the regulatory threshold, and the health policy context. They're all considered within this particular conceptual model. And this is really building towards a consensus position on the significance of a health effect. So as we've said before, any professional judgment on significance is based on a range of evidence sources and different lines of reasoning. And the assessment questions that we discussed back in slide 12 can help us lead or help us reach a conclusion on significance. Now within the technical guidance, there's a very good example given on page 152 in table 14. So what I'm going to do, so having talked you through the health sensitivity, the health magnitude, and the health significance, now I'd like to take you through an example of how this works itself out in terms of a hypothetical example. And in this case, the source of change is project construction transport, or what we'll probably commonly refer to as site traffic. In other words, the construction traffic on site during a particular development project. So the transport itself is the determinant of health because it's likely to impact on health, and this includes implications in terms of road traffic and roadworks that are likely to affect road safety, travel times, accessibility, and active travel. And we'll come to those in a little bit more detail just on the third row there under the main population health outcomes. So who is likely to be affected by this site travel in close proximity to their homes? So obviously the immediate groups are going to be community residents, but we've also identified that emergency services are likely to be affected as well. So in terms of the population, it's those who are likely to be living in close proximity to the development, but also the wider population as well. Children and young people and older people are considered potentially more vulnerable road users. Those from low income groups, for example, people living in deprivation, for whom travel costs or alternatives might be limiting or might impact their ability to get to work or to access services. Those with existing poor physical and mental health, in terms of any health trips and journey times, that's likely to impact them, as well as those who are likely to be affected by sort of access and what we describe as geographical vulnerability. In other words, people who experience existing access barriers or for whom close proximity to the project either can potentially increase their sensitivity to the change that's occurring in their area. So the main population health outcomes in this particular instance would be road safety, accessibility, and active or sustainable travel. So in terms of road safety, the health effects may be associated with the severity or the frequency of road traffic incidents. In terms of accessibility, this may be linked to the emergency response times, or indeed for non-emergency treatment outcomes or delays in terms of or non-attendance at hospital appointments because people simply can't get or they're delayed on their travel. In terms of active and sustainable travel, the health effects may relate to both physical health, i.e. cardiovascular health, mental health conditions, for example, stress, anxiety or depression. And again, these are all associated with obesity and levels of physical activity and can be impacted for the duration of the project, whilst the site traffic is perhaps impacting on active travel or sustainable travel. In terms of any known thresholds, if we think in particular in this instance about air and noise quality, these will be assessed separately under environmental impact assessment. So then we want to look at the likelihood or the causal pathway. And I'm going to kind of bring your thinking back to those three terms: source, pathway and receptor. And if we think about the source, in this particular instance, those are the vehicles on the road network, or the changes in the routes that link the community with any commercial services or amenities. Then we have the pathway, and this could be considered changes in driver delay, severance, pedestrian delay, access to amenities, potentially accidents and safety as well. And again, also to take account of the links between the physical activity and active travel and the links with emergency response times. And the receptors are those who are impacted the change. Those could be local road users, including drivers, passengers of motor vehicles, pedestrians, cyclists, users of public transport and emergency services. Then we have the evidence and the professional judgment. And I'm just going to summarise this quite briefly for you here. So we're going to think about the baseline information first of all. And in this particular example, we're going to make the assumption that the baseline indicates that the relevant sensitivities and inequalities identified in the scientific literature may be present for this particular community. In terms of the health priorities, so these would be the health priorities as set out, say for example, by the Public Health Agency or the local health department. They have identified health challenges for this area that are relevant to transport. So this is something that has come up before in this particular community. These priorities include supporting active travel and reducing rates of obesity and preventing poor health, ensuring access to high quality health care, that's our accessibility piece, and ensuring the transport infrastructure promotes social inclusion, well-being and social connection. Sometimes that can be lost with new infrastructure projects, new road networks that reduce the access and actually impact negatively on that social cohesion and sense of community that existed previously. The other piece is also around government policy, and in this particular instance we know that government policy sets out expectations for travel in terms of improving pedestrian and cycle links, keeping local health facilities accessible to all, promoting cycling as a major mode of active travel and a mode of transport, and also connecting people to higher earning jobs. And in this particular instance, the government policy also relates to providing reliable public transportation services that are accessible to all, including those with long-term health implications, any impairments or disabilities, and ensuring that the transport is affordable and reliable for everyone to access work, education and leisure. So what are the mitigation measures then? So in this particular example, measures have been put in place that will limit and manage the timing and routes of the construction traffic. So that may be, for example, during the school run in the morning between 8:30 and 9:30, that no construction traffic is allowed on site at those times, or it's reduced to a particular zone. Early notice to emergency services of any roadworks, diversions or closures, so ensuring that emergency services are aware of the changes that are taking place and any diversions that might be required or how it might impact on them accessing this community in the event of an emergency. And then finally, the third piece there is around the maintenance or maintaining pedestrian and cycle routes during roadworks or diversions to minimise the discouragement of active travel. We all know that it is a challenge to get your bike out on a cold, wet morning, and if you have an established pattern of doing that, and then that is disrupted and you find you can no longer take your bike, it can be very difficult to re-establish those good behavioural choices again in terms of active travel, for example. So ensuring that is maintained throughout the construction period is really, really important in this particular instance. And then just finally, what conclusions have been drawn as a result of looking at all of the different health determinants and the impacts on the population, and in terms of their significance and what has been concluded. So in this particular example, it has been concluded that the sensitivity of the general population is considered to be low. And again, you'll notice now that I'm using that kind of format that structured narrative that I relayed to you earlier. Routine statistics for the area show that the health of most people is good and their daily activities are not limited. In terms of resource sharing, most people would only make occasional use of the roads affected by the construction, with many alternative routes available. The score also reflects that the general population would have a high capacity to adapt to change in traffic conditions. So in other words, they will be able to find alternative means of transport or alternative routes during the construction time. However, that's what it's like for the general population. But let's look at other vulnerable groups. So it's been concluded in this example that the sensitivity of vulnerable groups is considered high. It's estimated that from a life stage perspective, a high proportion of pedestrians and cyclists are young people and older people as well, who make frequent use of services where access is reliant on affected sections of the highway network. In other words, travelling to and from school or daycare. Furthermore, this particular population is being described as having moderate levels of deprivation. And we know that deprived communities face greater barriers compared to the general population. Therefore, they may be more sensitive to the change in access to services, for example. Low incomes may compound barriers, resulting in limited capacity to adapt. Also, things like emergency services, ambulance services, are particularly sensitive to delays in response times, and this is a particular concern of the public. Overall, it was concluded that during the construction, the magnitude of change due to the development is small. In terms of road safety, the scale of change, it was reported that incidents would be small, the number of incidents would be small to negligible, but the duration of the change would be medium term. The frequency of any incidents would be one-off or occasional, with the severity ranging from minor through to fatal. Potentially fatal. The number of additional road incidents would be small, so there would be no or slight implications for healthcare services. And again, this example is the type of thing that you can repeat for other health issues such as travel times, accessibility, active and sustainable travel. And we've touched on some of them throughout that. But this really kind of gives you an example of how you reach a conclusion about a particular health determinant as a result of a proposal. I just want to mention briefly this idea of cumulative effects. Cumulative effects is a term you may come across in impact assessment more generally, but what does this mean? In this guidance, cumulative effects relate to either the combined effects of a single proposal or the combined effects of the proposal and other new proposals. Essentially, this means that one population group experiences several changes to their determinants of health, or in less technical language, everything happens to the same people. So let's look at this in a little bit more detail just over the next couple of slides. A proposal may affect multiple determinants of health for a given population. For example, changes in the physical environment, such as reduced green space and communal areas, may impact on physical activity, community cohesion, and mental well-being. If multiple types of health are concentrated to a particular population, additional recommendations or mitigation measures may be required. So if it looks as though a particular group or a particular community is being affected in multiple ways, then additional mitigation measures may be needed. Multiple effects may be due to the proposal. Multiple effects may be due to the proposal in isolation or when in combination with other new proposals. For example, a new housing development as well as an upgraded road network. The aim is to take a step back to see the overlaps in the proposal's effect and its relationships with other new proposals. Issues of equity or fairness for vulnerable groups may be revealed and can be addressed at this stage. There are two types of cumulative effects, intra-proposal and inter-proposal, and we'll talk about intra-proposal effects first of all. The cumulative effects of a proposal might mean that one population group experiences several changes to their determinant of health, or as we said in less technical language, everything happens to the same people. This can happen when different aspects of the same proposal overlap and is known as intra-proposal effects, or also known as in-combination effects. For example, a community living close to a construction site may experience increased noise due to the construction site activities as well as congestion on the local road network due to construction vehicles. At the strategic level, the impact of new legislation may be both to increase the cost and reduce the availability of a health promoting product or service for rural communities. The second type of effects are what we call inter-proposal effects. Cumulative effects can also happen if one proposal is carried out at the same time, i.e. concurrently, or soon after, i.e. consecutively, another proposal. This is known as inter-proposal effects. For example, construction traffic, we'll be coming back to this again, of two different projects might use the same route and thus impose a double burden on a community, or two or more new policies may target the same population group. In strategic environmental assessment and environmental impact assessment, this is known as cumulative assessment. HIA reporting outputs usually take one of two forms. This can be either ranking or prioritising effects. In other words, drawing conclusions about the significance of an effect and or forming recommendations, for example, for further investigation or changes to the wording of a proposal. I just want to say a little bit at this stage about the reporting process within HIA. So first off, it's good practice to include a non-technical summary of the health impact assessment. So this can reach a wide audience and is accessible to a wide readership. The HIA report should set out key activities and outcomes. And the aim of the report is to document the judgments that have been made on health based on the evidence that inform those judgments. And you'll recall that we talked about HIA being an evidence-based approach earlier on in the presentation. The reporting should be precise and concise, and health reporting should focus primarily on the likely significant effects of a proposal and on population health outcomes. An HIA will report a recommended change to a proposal or a conclusion on particular effects. HIAs may consider and report on outcomes that are below what we describe as the threshold for significance. So even though something is not significant, the HIA report may still include this. Reporting should be underpinned by the HIA principles, and those were covered in the online digital learning module. And the report should be a proportionate description of the methods, data and evidence used to inform the judgment. The next stage in the HIA process is implementation. To be effective, standalone HIA and health and environmental assessment findings must be followed through when implementing the proposal. The HIA process can support the delivery of the public health frameworks in Ireland and Northern Ireland, that is Healthy Ireland and Making Life Better. And this can be achieved through intersectoral working and an analysis of what health in all policies means for a particular proposal. In turn, the public health frameworks can support the delivery of health impact assessment by providing the mechanisms for the HIA findings, including recommendations and mitigation measures to be implemented. These delivery mechanisms include both the structure of the organisation in terms of its policies and priorities, and as well as the activities of an organisation. purpose of the health impact assessment is building towards developing recommendations or mitigation measures. In terms of recommendations, decision makers or developers may or may not accept the recommendations that have been put forward in the HIA. There is no firm or binding commitment to implement the recommendations, and it's important to note that standalone HIAs tend to present recommendations rather than mitigation measures. Mitigation measures, on the other hand, tend to be more closely aligned with environmental assessment, and decision makers or developers are committed to follow through. As I've said, mitigation measures are typically included within environmental assessments, and they are more enforceable than recommendations. In this slide, I want to say a little bit more about recommendations and mitigation measures. Standalone HIAs with no requirement for statutory output tend to present recommendations that don't necessarily have to be resolved at a given point, and which a decision maker can decide to accept or reject. Environmental assessment, on the other hand, requires the proponent of a proposal to commit to measures for mitigation and/or enhancement, and any decision about permission to proceed is often contingent upon these measures. So in other words, they must demonstrate how they are going to implement mitigation measures before they can proceed with their proposal. This is typically negotiated between the parties and then set out in a legal agreement. Standalone HIAs, on the other hand, have less authority to effect change because the proponent is not bound to the recommendations in the HIA reports. It would therefore be good practice for all forms of HIA to move beyond making recommendations and to formally secure mitigation measures and/or enhancement measures. But it is acknowledged that this can be challenging. Standalone HIA may or may not present conclusions on the significance of each effect. We mentioned that previously. But in contrast, health and environmental assessment, that is strategic environmental assessment and environmental impact assessment, must report on significant effects. The sixth stage in the HIA process is known as monitoring, and this involves data collection and analysis after the assessment or HIA report has been issued. The HIA itself identifies potential effects on health, whilst the monitoring will track the actual effects of the proposal, and it can be conducted at different phases of the legislation, policy, plan or programme. At the project level, monitoring will be conducted on the construction and operational phases, and may also be required during the decommissioning phase. It can be used to follow up on significant issues that were identified during the health impact assessment, but for which there were low levels of certainty. Monitoring is resource intensive, so it should be used in what we describe as a proportionate and time limited manner. The purpose of and governance and methods for the monitoring should be developed appropriately. Resources should also be secured at an early stage in the HIA process. Where possible, monitoring should make use of routinely collected indicators rather than setting up new data collection systems. So for example, using health survey data, or in the case of Northern Ireland, we have the Northern Ireland Statistics and Research Agency. Using the data collection systems that they have in place would be a really good starting point. This could include, for example, routine public health data or other data from population censuses. However, careful consideration should be given to what we describe as the spatial and temporal relevance of these indicators. So for example, in terms of the spatial aspect of it, does it cover the specific geographical area? And in terms of the timing, is the survey conducted frequently enough to give you a good indication of the impact of this proposal on the health outcomes for the community of interest? It's also worth noting that census data may provide small area data, but it might not necessarily identify the short and medium term trends, because census data tends to be collected every 10 years. So you may need to look for other data sets that track changes in health outcomes on a more frequent basis. If it's considered appropriate to collect personal data, then you need to think about the governance around that, including data collection, storage, analysis, anonymization, deletion of data and reporting of it. And it might be more appropriate at this stage to involve a health authority to undertake this type of work rather than the proposal proponent or indeed a third party. It's also important that there's continuity between the indicators that have informed the baseline or the population profile, because that in itself then will help improve the accuracy of the monitoring. Evaluation can take three forms, that is process, impact or outcome. Each is looked at briefly in turn in this slide. Firstly, process evaluation. This examines how the HIA process was undertaken, who was involved and how useful the process was. This can help to determine whether the HIA added value to the process. The second form of evaluation is impact evaluation, and this examines whether recommendations from the HIA were accepted as measures by the decision makers, and if not, why not? And thirdly, we have outcome evaluation. This examines the health outcomes of a proposal after the HIA has been conducted. For example, whether the anticipated positive effects on health, well-being and equity were realised and whether the negative ones were avoided. In this next slide, I've provided you with a list of what I hope are some useful links for further information about health impact assessment. You'll see a range of regional and local links, as well as a number of information portals or hubs that provide access to HIA reports. In particular, for a more local one, I would recommend that you look at the Wales Health Impact Assessment Support Unit. Also, the University of Liverpool Environment and Health Impacts Hub contains a good range of guidance documents on health impact assessment as well. There's a number of other documents there which I hope that you will find useful. Thank you again for your attention. I hope this has been an informative session for you, and I look forward to seeing you all on the 6th of October. Thank you.